Welcome to the Eureka Springs Hospital Workshop for May 5th, 2025. Can I have a roll call, please?
David, Commissioner. Carlisle.
David, Commissioner Carlisle.
Kate Driver, Secretary.
Brian Byler, Vice Chair.
Sandy Martin, Chair.
Jody Edmondson, Interim CEO.
Cynthia Asbury, CFO.
Lana Mills, Nursing.
Philip Schultz, nursing.
Thank you all for being here. Sharon Naremus is the only one that is absent. Should be a short... Oh,
Commissioner.
sorry. Keep speaking up. Vivian Smith, Commissioner.
Yep.
First, we want to go through staff updates and fill us in on what's been going on. I know you've been busy.
Yes, I'll start. We've employed some paramedics to assist in the emergency room. One of our paramedics is updating and activating the emergency management procedures. We're now back in compliance with the Regional Emergency Management Committee. All of our staff will be doing FEMA training online as a part of that, and we'll be working with the local police and fire departments on some drills. We are meeting with the Rural Health Redesign Center this month to review our service line assessment, and I did give you each some information on that. Dr. Stubblefield, the lab director, was on site last week, and she plans to have blood product back in-house within 7 to 10 days.
Excellent. That's a lot of progress.
Yep.
A lot of progress. Any questions or comments for Jody?
Well, it could be for Lana, so I'll wait.
Cynthia, do you have anything? I know you've been audited.
Yeah, so we just wrapped up with Forvis on-site last week. Over the next couple months is just typical standard practice of them requesting additional supplements, getting copies of some of their sample items. So we'll just continue working through that and hope to have that wrapped up before the end of summer. So, and they'll then present a report to the commission and the city council if they would like. So
Excellent.
other than that, we just continue to look at cost-saving measures, looking at contracts, ways that anything we can do to save money, reduce expenses. We will be bringing some of our services back in-house that we have contracted out on the financial side and spreading the task between the financial team. So.
Super. Do you think we need to revise our budget and kind of take a look at that? Do you think the June workshop would give you enough time?
Possibly, yeah. We can touch base and see where we're at with the Forvis audit between now and then too, to see, make sure everything's moving along, because they're sending daily lists. You know, I mean, it's just kind of that back and forth. So
okay.
Work through. And because we'll have our cost report as well, it's due before the end of May. So.
Okay, great.
So are you thinking a budget workshop the first Monday in July or first Monday in August?
Possibly.
Okay.
One of those two.
Is that the one with the city council, or is that the one we're still scheduled for in June for that Thursday morning? Is that still on?
We're going to do a different one
Okay.
just on helping them understand our finances.
Okay.
The budget is really ours to do.
Right.
And we need to go through it and, take the time to go through line items and staff recommendations for cost savings, as well as any additional expenditures that we, need to do. So that's kind of our job.
Okay.
To do on that. Any other questions for Cynthia? Thanks for putting up with the audit, both of you. I know it was busy. Lana.
We just are in the process of upgrading the old TriTech monitors for the bedside monitoring, and we are in the process of upgrading those to modern bedside monitoring, and they are going to be installed this Friday.
This Friday.
Great.
Yes. And report on some of our numbers. January total ED visits were at 119, and February 122, March 126, April 139, and as of this morning, we're at 29 patients in the last 4.5 days.
Oh, God.
Wow.
You've been busy.
That's going up.
It's going up.
Yeah.
It sure is. I mean,
And I wanted for the two of you to read, I think it was sent out, but there was a recent patient that emailed the mayor, and I just want to read it because I think it's important. I hope this message finds you well. I'm writing to share a recent personal experience that highlights the outstanding service provided by the Eureka Springs Hospital. After suffering a broken arm, I visited Eureka Springs Hospital, where I received prompt and compassionate care. The staff quickly provided me with a splint, performed an x-ray, and administered a sedative to help manage the pain. Their professionalism and attentiveness were greatly appreciated during a stressful time. What stood out most, however, was what happened next. When we arrived at the emergency room in Fayetteville for further evaluation, we discovered that the Eureka Springs Hospital had already checked us in. As a result, I was seen immediately with no time spent in the waiting room at all. This seamless coordination between facilities was truly impressive and a testament to the level of care and foresight shown by the Eureka Springs Hospital team. In times of medical need, having access to a hospital that is not only capable but also proactive makes a world of difference. I wanted to take a moment to recognize and commend their efforts and to share this positive experience with you. Thank you for your ongoing commitment to supporting the health and well-being of our community. So thank you all. Very, very proud of you for that.
I want to repeat the phrase seamless coordination, no hiccups, is what that means. And also I would like to point out for anybody who's listening out there that 7 patients a day right now sounds like what the numbers are. And to me, that means that there are plenty of people out there who desire to use our emergency room. So the charge that nobody wants to come to our hospital is no longer valid.
We're making changes, and we're making positive changes. And the patients are seeing that, and the community will see that, and they'll see the changes we're making.
How are things going with the new lab staff and their checkoffs and getting comfortable with the hospital and their processes? How long have they been with us now? 2 to 3 weeks? Or is it a little bit longer than that? And if you don't know the exact answer, that's okay. I'm just roundabout.
It's staggered. They've kind of come in,
Okay.
but I think probably about a month ago we started hiring. And then I think the last one was onboarded the 26th or 27th of April. Is that correct?
Yeah, and the Dr. Stubblefield is going over all of their checkoffs and making sure everything is correct and on board and making sure we're in complete compliance.
And Stubblefield's the pathologist?
No.
No, she's
No.
the lab director.
Okay.
You got a pathologist, Dr. Dorina,
That's what I
lab
thought. The
director,
new
and a
name.
lab manager.
Okay.
Yeah. And then 4 PRNs. Four PRNs, 2 full-time? Okay, great. So it's been a slow process, but boy, the checks and the balances to make sure that we stay on track with this that's part of what's prolonged it, and finding the right people, so,
But the ones who have come on have stayed.
yeah, critical. Anything else, Lon? No? Velvet, Miss Happy Face.
The last time you tried to take notes, you were like, make me something
Oh,
to take notes of, so.
Thanks.
thank you.
Thanks, Phil, for all that.
I don't want those ladies to think I'm doing anything.
This is better than putting mulch in the front yard, though, right?
That was a lot more fun. Most of what
Looks
you
great.
have in front of you is all trauma-related. The Department of Health site visit is scheduled for June 4th. And these are the things that they're going to see that have been done thus far, most of which we talked about probably in the last couple of meetings. When the Department of Health comes on the 4th, I expect them to find deficiencies. There's no way around it. They're going to look at 22, 23, 24, and the first half of 25. I don't have any records for 22 or 23. I have a few chart reviews that I can find, but no education, trauma education, no trauma chart review, meeting minutes, anything like that. If it existed, it does not live at the hospital. So,
What does that do to us?
well, it looks like they didn't have any meetings, no physician peer review meetings, no operations meetings, no chart reviews, no trauma education, no process, really, for 22 and 23. Now, did they? I think they did. I just can't show any record of it.
Wasn't documented.
There's none. So what the department will do is they likely will cite us with a deficiency for what we can't show from the past, but they can't shut us down because I can show it all exists now as of February 1st, roughly, mid-February. They'll be able to see meetings and chart reviews, and all the nurse education and physician education's all up to date, all their certifications, that kind of thing. All the practice management guidelines have been revised and updated, all the policies, pretty much the entire program kind of put back together. And so they don't have to, I mean, they can't say we don't have it, but they don't have to like that we didn't have it. You know, they very well could do that. So what does that mean for us? They're not critical deficiencies. They're not shut you down deficiencies. They are, you have an opportunity to show a track record of what you've built, and we'll be back in a year, is what I fully expect for them to do.
They'll do a follow-up in a year.
They'll do follow-up in a year, because I have February, March, April, May, 4 months of a program to show them, where I ought to have 3.5 years, and I don't. So they will see a 4.5-month process that works well, but they want to see a larger scale volume of that working. So, and that's pretty common for them. That's really what I would, if I was surveying us, that's what I would do. I'd be like, this is all good. We'll see you in a year.
Yeah.
We'll be back in a year, which is just a chart review visit really in a year.
So they'll honor the REH beginning forward.
Yep. It won't keep you from grant money. It won't keep you from designating. You'll get provisional designation after that time period.
Okay.
Yeah.
Just basically like a slap on the hands.
Yeah,
Correct?
I mean, because I can't show it. You know, you have to have it.
Right.
Like peer review meetings, you have to have so many a year. And that's the physician peers looking at cases and cussing and discussing different things in the cases, opportunities for improvement. And I don't have any record of any meetings ever prior to the ones we've had in the last couple months. Now, if they were there, I mean, I've been through every desk, every file cabinet, every notebook, everything, and I find nothing.
Was there anything such as, what a concept, an electronic repository of any of the reports or anything that was going on? Or was that?
I've not found any record of anything electronic for the trauma program at all. It's all paper, at least what I can find. And the things they got cited for the last time, they were easy things. They're things we won't get hit with again, education records and physicians have an ATLS and that kind of thing, and we're all good for those things. But the past record, charts being reviewed, cases being discussed, and what they look for, and it sounds very complicated, and it's really not. So when we look at a chart, our whole goal is to find something wrong. It seems crazy, but find it what's wrong and make sure it never happens again. And then document the process that you're trying to fix it. What are we doing education? Are we hanging up a sign? Are we doing an in-service? Am I putting a little note on the computer? Like, what am I doing? And then you monitor it. Does it work? And then if it does, you go with it. If it doesn't, then you think of something different. But I can't see that at all. I can see a trauma log, kind of, where they knew what cases were in, but I don't know what they did with them. So there's just not a lot to go by. But
Yeah.
I can't, the department's going to see it. And we're going to be transparent. We're going to tell them when they
Absolutely.
come. We're
Right.
going to say, here's what you're going to see.
Absolutely.
Yeah, they're going to see that. So I've
Well-
just put in there some of our challenges, some of the things that we continue to have a little bit of issue with, kind of what's good. Not everything doesn't have to be always bad. Charting continues to be an issue. I know that Lana has kind of been on the forefront with Cerner to try to figure out how do we fix our electronic health record. I mean, imagine it's the most bare bones of charting that you can have. Like, I can tell when the patients come in, I can tell what time, and probably what their chief complaint was, but very little behind that. There's a lot of buttons that we don't have to click, that we're able to bypass, that we should be. So it just needs a little upgrading to give a more accurate picture of that patient's stay that's there. So
Are
we
they
do have some
being-
opportunities with Cerner to try to fix that.
Are they being cooperative?
Very much so.
Good, good, good.
Yeah. I don't know if there's cost involved. Like, we're trying to figure out, there's an opportunity for us to go to Kansas City in July to try to work with them, and we're trying to figure out, can we fix it in that setting? Do we need them to help fix it? But, there's a lot of that documentation that just gets omitted because there's no hard stop to it. They don't have to put it in there.
So in essence, we have software that's just, like you say, the fundamentals, but the templates haven't been implemented?
No.
Or you have to build your own template? There aren't some out-of-the-box templates that Cerner has?
Basically, it's my understanding what we got with Cerner was right out of the box. It's the most generic form that when we had opportunity to say, okay, we want to establish every patient needs to be screened for mental health.
I remember now.
Do we have that? And you can bypass. You don't have to answer that. That should be a hard stop. You should have to answer. Are you a fall risk? You should have to answer. I think it's harder for me because I review so many charts for the care, and it's just super hard to see it. And I'm excited about the monitoring system that TriTech is bringing out of Memphis. It will populate the vital signs from the monitor into the electronic health record. You don't have to be dependent on somebody to enter them. So once they hook them to the monitor and they set every 15 minutes, every 30 minutes, whatever, it'll automatically go into Cerner. So at least we can see some vital signs for the time that patients.
And those are being paid for by a grant, aren't they?
Part of that will be covered by a grant. Part of it will be just from our REH initial conversion funds. So,
Okay.
But it was definitely an upgrade that was past time, due for
Right.
the set.
But it'll stay out
over
it'll
10
stay out of
years
the
old.
general fund overall, right?
So you're saying that we passed when we had the opportunity to put in the filters that would have made our life easier. That was
Correct.
back
I
in the
can't tell
early
you why
days.
it didn't get done. I can just tell you it didn't get done.
It didn't happen.
It didn't happen.
Well, I
We
remember
just
some
took.
discussion.
It would be like taking your TV right out of the box,
Right.
and you don't program, or your computer,
Right.
your laptop, and you don't do anything to it. You just turn it on and start using it.
Right.
And that's really that's what it looks like from an outsider looking in. That's what it looks like.
Everything's by hand anyway.
And it shouldn't be. It should be a lot of clicking, but it should be populating, comfort measures, blanket given, ice water given, patient to bathroom. You're clicking on it, but when you open it up, you don't even have those
It doesn't even
options.
present you with options. You have to put it in, yeah.
And not really a place to free text it even.
Okay.
We don't really want them to free text. We'd rather them select
Right.
those things, but yeah. So we're looking to kind of upgrade that.
It's going to take time to get it, it's going to take time to get that template where it needs to be, right?
Yeah.
And how does that flow through on the financial end of it? What's the impact there?
Some of it is just, like she was saying, it's just, health record stuff that's mandated, depending on reporting agencies that we're supposed to be gathering information. Sometimes we do bill lower levels for ER services because we're not capturing truly all the care we did provide to the patient because we don't have as detailed of a, medical history or surgical history. We are missing some of these key elements, or, their nurses' notes aren't that lengthy or stuff, just because every bit of it is just time consuming. So there is no templates in there to be like, okay, chief complaint was this. We know we kind of standardly always do this. We're kind of populating some questions on there, so.
So when we were doing the Cerner build-out, was it up to the department heads to say, this is what my department does, and I see what your base template
Yes.
does, and these are the things I want you to add in so that we can click and not have to be doing so much free text?
Correct, yes. There was order sets that were not approved and signed off. We have backed into that paper trail where Oracle did give us deadlines of saying if we didn't have things approved by certain deadlines, they weren't going to make it into our Go Live system, and those were not met
So
or
we-
approved.
So we did have the opportunity.
We did, yes.
So when we're doing this, though, basically, as they go through like a patient situation, they're inputting information. Does that then become the template? I mean, is it in our process of seeing a patient, dealing with a patient, or is someone having to go above and beyond, away from the patient to do all that information?
The templates are built on the backside in what they call like a bedrock of Oracle, because then they're in there, built on the interface, like in the EHR system, so you can grab them and pull them into patients. So they will have to, they're a separate build out to then be implemented into our system.
In other words, it's not a smart system that
Correct. It
sees
doesn't
what
like,
you're putting
yep.
in and adapts to
Yep.
receive that kind of information.
I think there is some that you can do, but those are just user specific. Like you can set and create some of your own, like my favorite kind of things, but.
But
as far
overall,
as
you still got to, so basically, it doesn't matter if a patient comes in, it's not going to save us. I'm looking at the amount of extra time now these ladies are having to put out there to put that information in there, and this really doesn't, seeing a patient doesn't really help other than maybe jog your memory that, oh, we've got to get that in there. I mean, that's about all it does for you, but you still have to go back and do it.
Yeah.
It should be set up when you go to open the chart, there should be headers that you will have to address before you can close it. You know, patient past history, social history, communication barriers, you know, are they English, are they Hispanic, Hispanic, are they Russian, certain things like who do they live with? They live with their spouse. Where do they live? Inside, outside, shelter, nursing home. There's certain things that walk right through, and you should be able to chart any average ER patient in under 5 minutes at the bedside. You should be able to, and put all of those things in there, but the EHRs are intended to line those up to help me remember, to not make me have to go from here to here to here, and then it doesn't ask me even all the questions. They should be all in almost bullet points right in a row. Yeah. And when I go to try to close the chart, it should flag and say, hey, by the way, you didn't DC your IV. You didn't put your dispo assessment, like Atlanta's been looking. We don't know what happened to the patient. Where did they go? They transferred, discharged, home, shelter, PD, where did they go? And it just doesn't. It's, like I said, it's the most basic, and it's tragic that it is that way, but it apparently is fixable through Cerner. It's just going to take a little bit of work to get it done. And like I said, I think I'm the most sensitive to it because I'm digging in the charts looking for stuff, and it's just not there. I can't tell it was done or not done.
Which we're blessed to have you because of that.
Yeah. We also are struggling a little bit with pre-hospital notification, documenting that. It's become apparent our version of Pulsara. You know what Pulsara is? It's our electronic notification from EMS. It's basically a program that they use that they send their radio report. Instead of doing it on a radio, they send it electronically. And it's a program we receive through the state, but we don't have any way to record it and put it in the patient's chart. In trauma, you're supposed to be able to document, what did EMS tell me? I don't know what they told me. Their pressure was 80, the patient is not breathing, the patient has a large fracture, whatever they told me to help me prepare for their arrival, we have to put it in the chart. So you can either print Pulsara, you can fill out a sheet, or you put it in the electronic health record, and we struggle to do that. But Pulsara, we should be able to print it, and we can't, and we don't know why. So I have a call in for the Pulsara reps to try to figure that out. And I think it's probably because we don't have there's an update that needs to be done to our program, and it's not been done. So we just
now that's what you got from the state.
Mm-hmm. Yeah.
So, and nobody's said it needs an update.
Right. Yeah. And I just happened to figure that out late last week, just honestly pushing buttons, just going, why won't this print? Because I've seen the other, in other places, there's a place that allows you to press the little 3 lines and it comes up print. It asks you the question, and ours doesn't do that. So I don't know why. So we're working on that.
And so that should allow you to interface with our software at some point.
Well, it won't go into your EHR, but you can print that and then scan it into the chart under outside records.
Okay, so you've got it.
Mm-hmm. It'll go in that way. Yeah.
I have a couple of questions.
Sure.
The pediatric ER room or treatment room, does that table allow for weight to be obtained? Does that even exist? A table, not a stretcher, but an exam table that they would be on, that you could get their weight?
We have 2 pediatric scales in the ER.
Are they, well, what am I trying to say? If they came in and and you didn't want to have to move them very much, but
Right.
you needed a weight. Is there a
That's
way
way
for one of those scales to be sort of
Are they-
connected to a table?
Some of the
so that-
gurneys.
Does that make sense what I'm trying to say?
Yeah, it's called a way bed.
Oh,
The
yeah.
gurneys, they're called trauma gurneys, actually,
Uh-huh.
and I am biased because I think trauma owns everything, but they were generated in that world as stroke and trauma, so you could weigh that patient really quick and know how to drug dose him.
Yeah.
And it has a scale on it, and they say, yes, that we have some, but I have to look to see.
Oh, so
If
you
they've-
think ours might? Oh, cool.
Yeah, when we updated the gurney, the stretchers last
Way cool. Okay.
summer, they do.
So we do
at least
have one.
one, if not two, that do weigh.
Nice, nice. That's wonderful. And then warming fluids and blood products. How much are Ranger warmers?
Any idea? I'm going to say probably right around $1,200, probably,
1,200?
if
Okay.
not less.
That's not horrible.
Yeah, not at all. The one that we have, I got to tell you, in 35 years, I've never even seen one. It's like, I mean, I don't know. I'm sure it's maybe from, what do you think, the 80s, early 90s, maybe?
Okay.
But I don't even know how to use
We
it.
might be looking at a new one then.
Yeah, yeah. Well, and the Ranger is, the thing that I like about the Ranger is you can have just warmer at a really decent price, and you can use an insert for it, the disposables, that's only to warm. And then if I want to give it rapid and warm, if you wanted, you can buy their rapid piece, or we can just use pressure bags up top, so I can have fast and warm. And it's not really for trauma, it's trauma, sepsis, hypothermia, pediatric patient, geriatric patient, you know, and Lana and I kind of just really realized that we didn't have a way to do that, how to warm them.
Yeah.
We don't have a fluid warmer, you know, way to keep fluid warm, so you have to have some way to give something warm. And blood should always be given warm, should never be given cold.
And just backing up to Cerner and the build-out, does lab, did they have a component in that, in the Cerner, in the charting?
Yeah, each department has a
Each
section
department.
in the chart they can work, and each one of them almost have like a separate application that references just their department-specific kind of tasks, so.
And so lab management would have been involved in that build-out?
Yeah, yes, because if there were
Process too.
certain,
Okay.
order sets saying, every time
Okay.
this, chest pain comes in, we always do this within lab, this within nursing, this within radiology, kind
Okay.
of those standardized things would have all been involved.
Thank
so.
you.
Only other thing is injury prevention, and I gave you a list of our 5 things that we're going to start to target, and really, honestly, I need the state visit to be out of the way to have time to do any of that. We have opportunity for Think First. We have membership of it, and I think we've talked about a little bit about that. We'd like to see what the logistics is to make our old cafeteria room downstairs into like a classroom, like where we could have people from the community to come in to have classes on stroke and suicide awareness, falls, defensive driving, whatever kind of, we should base it off whatever we're seeing the most, mechanism or chief complaint in the ER, so we kind of know the pulse of the community, what their need is.
So is
But-
that like the same or a different community room that we talked about with telehealth?
Same, down in that
Same?
lower level. Mhm.
Okay, good. I don't remember where that was.
Different,
Yeah,
Different what?
different than what we were talking about last time.
different.
Different community room.
Oh,
Yeah.
and the only other thing, I put Braslow with you guys, that's probably been, I'm sure it's the bane of Lana's existence, she's worked very hard to get us a Braslow cart with pediatric appropriate drugs, pediatric appropriate supplies, but sometimes when you say Braslow, that doesn't mean a lot to someone. But the sheet that you have, it's not color-coded, but when you look at it, each of those is a color on this cart, and each bag, the drugs are all listed on there, so if I get a kid and I know where they fit on that Braslow tape, you lay the tape out. If they're yellow, then I open the yellow drawer, and it has all my drug calculations, sizes for everything is all on there.
That's
It's really, it's state-of-the-art, it's really standard ER is really what it is, but I'm thrilled that she's worked so hard to get that finally put together for us, and worked with the pharmacist and made sure that we have all the appropriate drugs, because we take care of a lot of kids. I'm surprised how many kids that we take care of.
So circling back to the month of May and the average of 7 patients coming in, Has there been one diagnosis more than any other of these 28 folks that we've seen so far this month that sticks out to you? And if nothing comes up, it's all good. I was just curious as to, 7 or 8 a day is quite a bit more than what we've been seeing, and maybe it's just because the town's gotten a lot busier.
From a trauma standpoint, fall is your top mechanism of injury.
Had some falls, okay.
And you want to say, is that a geriatric population? Yes, but we see a lot of hiking falls, slipped on wet rocks, slipped at the lake,
Okay.
that kind of thing where they're looking to fall, and it's not always our elderly patients. They're reminding me to talk about the ABLS class. I contacted Arkansas Children's. Arkansas Children's gets paid grant money to put on so many advanced burn life support classes a year in the state, and they will bring them to you. I contacted their event coordinator, and she's agreed to bring us an ABLS class here. I talked to the chief at the fire department, Inman, and he said, yeah, he and Fitzpatrick said they would love to host it, which is great because we really don't have a very big place to do it at the hospital. It requires a lecture room that'll seat 30, and then you have to have 4 breakout rooms for the testing. So advanced burn life support is like CPR for burn patients. It teaches a first-line healthcare worker how to take care of a burn, each of the components of it, and it's taught by an American Burn Association accredited hospital, and our closest one's Arkansas Children's. We have Mercy in Springfield is as well, but instead of us going to Springfield or going to Little Rock, they're going to bring us the class. So it'll be for 25 people. It's kind of a first come, first serve. We'd like for EMS and ER to have that option, but anyone in the community could attend if they wanted to. They have to be a healthcare worker to get the certification. It's a 4-year certification class. Usually, if you took it outright, usually costs $300 or $400, and it's going to be grant funded, so it won't cost our guys at the fire department anything. It's 7 contact hours for them and covers, I think, 6 of their required areas that they have to have education for in there, but it's actually a test, lectures, and then the afternoon is testing. They actually test you on moulage victims to know that you know how to take care of them. We've had a couple of burns that when I go back and look at the charts, some of the care was probably not the standard of care, and so that's really what kind of pushed it, is to get us up to speed on taking care of the burns.
That's
But
great.
it'll be, we'll open it to whoever wants to come and take the first 25. So, and Holiday Island would be involved in that as well. But the chief's agreed to host it. He's got a place in the bays to set up 4 testing stations, and then his classroom, he said it's big enough for 25.
That's great. I bet he's thrilled with that.
Yeah.
Yeah, saves money and gets
Yeah.
certification.
Well, and it's burn season really honestly doesn't start till October, but that's kind of when burn season starts because people start burning outside. It's not necessarily during the summer, but it starts in the fall.
So between Eureka and Holiday Island, how many potential? You think you'll max the 25?
Yeah. Yep.
Easy?
Yep. We'll take Eureka and Holiday Island honestly together. Let them sign up as many as they want, and then we'll go to the hospital and see who wants to go. And then if we have seats left, then we'll open it up to Harrison or, across the
Huntsville.
state line, anybody who wants to come.
Yeah,
The
Huntsville
healthcare provider.
probably could use it.
Yeah. We just have to provide lunch. Arkansas Children's can't use grant money for food. I told them we would provide lunch for them. And that's kind of standard for the Department of Health. They won't let you use it for food.
That's great. That's great. It's a lot of
Awesome,
activity.
awesome.
Another question that we haven't talked about yet. How do we think, and I guess pull Brian in, how are we doing with our relationship with the Eureka Fire Department and the EMS? So are we friends again?
Yeah, I think we're doing, sorry. In April, we had 20 EMS calls or patients coming in, and so far we're at 9 in the last 4 or 5 days.
Yeah, I've been seeing the ambulance stay in town more than go to the east.
Okay.
Yeah, I think they're finally really getting on board, I really think there's a real desire to make it happen.
And I think the training, the community
Yeah,
outreach,
yeah. The
biggest thing to me is the communication and the consistency,
yeah.
and that's what we're demonstrating over and over and over again. And that's what's going to kind of offset, I think, some of the questions in the community as
Yeah,
well as at the
absolutely.
EMS.
Great.
Well-
That's good news.
The number of visits is an obvious point, and whether it be tourism or local residents, it's a good thing, period. Because if anybody gets treated well, especially if they're even visiting, they're going to tell other people. And it's just going to continue to multiply, you know?
Yeah.
Great.
So, yeah, we're moving the right way, so.
Anything else, Velvet?
I've got a question.
Yes, sir.
Just going back, you mentioned prior citations for trauma infractions or whatever. Were those in the past years?
You're surveyed every 3 years, so it would have been
Right.
3 years ago. 3 years ago at the start of 2025, so what would that be, 2021?
Okay, so, 2021? Oh, okay, so it wouldn't have been
Was
in
it
the period.
22?
I was
Could
just
have been
thinking.
May of 22, maybe.
Yeah,
That's when they were here.
but that's a period for which we have no records.
Correct.
But obviously, we were presenting something to them if we stayed open. So it's kind of like our records have disappeared. Is that a fair inference?
Did that overlap with the management company?
I can say that I can't
No,
locate
that was prior.
Pardon?
I can say that I can't locate them.
There you go.
And I've been
Okay.
through all of the offices and file cabinets and things where they were, because I have some chart review sheets, so I can see where some charts were looked at.
Mm-hmm.
But as far as meetings and physician review of the charts and operations, you know, the state programs mandate 2 meetings. One is physician peer review, so your physicians get together and discuss the decisions related to the care. And the other is operations, which is that patient's journey through your facility, lab, radiology, registration,
Right.
nursing, you know, and that's where you decide, do we have the right equipment? Do we have the right supplies? Are we quick enough to CT, you know, all the things that would happen. And I can find, if it's there, I've looked through every notebook that I can find in the entire building, and I find none.
Yeah.
Well,
Well, sitting as a commissioner for some of those years, you know, the idea that we're not running records of the things you do to stay in compliance with all the various entities
Yeah.
seems kind of impossible. And so it just leads me to the personal conclusion that a bunch of stuff disappeared magically at the time when we have had our problems.
It either disappeared, I can't find it, or they created it prior to the state's arrival. And I don't know.
Thank you.
I don't, and for me, honestly, it doesn't matter. I mean, I can't show it. So all I can wow them with is where we're at now.
So they
what
come-
we've created going forward.
They come every 3 years, they do an audit every 3
Correct.
years? Okay.
Now, for your big visit, and just like what we're talking about, if they find something that they want you to fix, they give you a provisional, which means we'll come back in a year. And then theoretically, you could get secondary provisional, they'll come in another year, and then you'll be due for your 3-year. But it looks like they got provisional the last time for some things. And I mean, there's quite a few things. But we won't have any issue with what they found prior. It's just now I don't really have a lot to show them for a program. If you said, show me what this program has been doing in the last 3 years, I really can't do that. Not to mention medical director's different, program manager's different.
They have previous,
Registry's
and then there's a
different.
whole,
Right.
Yeah,
and then we pick up.
yeah.
Yeah.
Yeah, a lot of the records we discovered were
Yeah.
missing or somewhere. Okay. Anything else for Velvet? No, good. Cool. Pinnacle had pitched us, because we have a whole bunch of site visits that they come up for because of our technical challenges and issues. And so they pitched us in conjunction with the city, or hopefully in conjunction with the city, $3,000 a month on top of what we're paying them now to have someone on site Monday through Friday. And we would provide an office space. We had talked about it, and we were kind of comfortable with the hospital doing 1,000 plus the office space. If the city would share between, they've got city, they've got parks, they've got public works, and a couple others on them, if they would split the other 2,000. They're not interested in doing that. that because they didn't have as many visits. And when Pinnacle went back and researched it, it was right. They really couldn't justify the $2,000. So we think it's a good idea, and we think it's necessary, particularly with what they're going through now with the upgrade and the new servers and everything. Question is, can we afford it? And is the commission willing to do it? And is that something we can absorb?
I mean, Cynthia,
Comfortably.
do you feel like it's a necessity to have someone there 5 days a week? Is it?
I mean, sometimes it's not 5 days a week, but there
Okay.
is times where, I mean, we do have issues that arise and we pay, they drive over, it's an hour and a half, and they come on site to help troubleshoot things or when there's issues. Part of that is, I mean, sometimes I'm pulled away from my day-to-day to resolve, in-house IT things just because it's easier than calling them or having them come over, again, because they're an hour and a half. So, I mean, I do think there's a benefit to it. I'm kind of interested to see kind of how they rework. I know they talked about doing an addendum and reworking the contract, kind of looking at it. I'm kind of looking at the analysis with that and seeing
I think it's just
us for the whole cost.
adds $3,000 on top of what we pay. We pay about $7,000 now?
That is correct.
And
I
what do
mean-
we pay in the incremental travel on top of that?
And that's exactly where I was about to say. I broke out where we've been paying for their visits because we do have to pay for the mileage and time of them sending a tech over. And we've had a lot of visits. I mean, I think it was 29 in the past 45-ish days, 2 months. Right. And that is because, something goes down, the internet's down. Some of these installed equipment, they're going to be on site Friday for, TriTech because they're dropping in routers and wireless connections and stuff. So, we just have a lot of need that, sometimes just our day-to-day. Also looking forward, we do have the huge upgrade of equipment with the new server install tentatively for the fall. We definitely would benefit by having a tech on site that's already comfortable, used to our workflow and everything else, because when we look at taking on that hit, we're going to need somebody there because there's a chance a lot of things could break, honestly, truthfully, in that installation of getting everything up to date where it should be. Hope not, but.
So basically, we're looking at what, 3 or 4 months before the big upgrade really starts to take place, correct?
Correct.
So if we're doing it, we're going to obligate to $3,000 a month for the next 3 or 4 months.
Well, it'd be a position. They're going to bring in staff, somebody in our facility. So, I would say, it's not even just a short term of like, oh, we think this person's only going to be here 6 months.
Right.
When we look at what we paid our previous IT staff, we did have 2 before, been at 2 full-time employees. When you're looking at their benefits, matching taxes, everything within that.
Yeah, we've
this
saved,
still comes in under what we were paying 2 full-time
Yeah.
employees
Okay.
before.
Okay.
So, and the difference is we have somebody on site, immediate response. We're not having to call in and saying, hey, we need help with this username or password. Or it's not, hey, Cynthia, we need a password reset again or something like that. That means I'm stopping my day-to-day to help assist in that because sometimes it's easier than the phone tag back and forth of getting access.
It's just going to be critical to have somebody there when we transition.
Yes.
Because there are going to be issues.
There's going to be issues. There's
Yeah.
things within, we paid for them last week to come on site to help within some, they're on site at least once a week, if not more than that already. So,
With Cerner doing their thing, I would think that would give you some comfort as well, some relief. What do you think, Jody?
So would this be a month-to-month 3,000 that we wouldn't be obligated to for a full year? Is that?
Is it a contract, a year contract, or?
It's an addendum to our existing contract.
Okay.
Yeah.
So if we go through this phase where we're needing them at more acutely than, say, when things get regularized, should that happen, then could we back out of it? Could we take that? Could we?
I do think that option is there, but I think the reality is we are always going to need an IT tech. We are technology-based 100%. We're moving
We're
forward with
driven.
UAMS and the telehealth. That's going to require a lot of IT help
It's
and
gonna be
support too.
huge.
Yeah.
There's just a lot of things we're moving forward and doing,
but-
and everything we do revolves around the IT infrastructure working correctly.
Sure.
But
The
now-
other thing too is that, we had huge issue with Cox and internet and having Pinnacle on site there. And I don't know if they can put in some redundancy to where we don't go completely down, but, we're at the
Sure.
mercy of Cox as well. So having that level, that quality tech support, I think is critical, particularly this year. Sorry, Brian.
My question in that thought process is we're already paying Pinnacle a monthly contracted for assistance or service. So basically we throw that and then throw the 3,000 on top of that. How do we stand versus having the 2 ITs that we had before? Are we still anywhere close to being in the same ballpark of figure? Are we still below it, or are we?
Or we would still be below what we are paying our 2 full-time techs.
Yeah, then I think we're not losing anything then, you know. I mean, we didn't replace the IT people because of Pinnacle.
I think we're gaining.
And I think it's a win-win because I think we'll get better
I
resolve.
think our skill set and the knowledge base we get, because when they do run into
All
an
the
issue, something they haven't seen. I
Yeah,
mean,
all
they're-
the everything becoming such high-tech thing, I think we're probably at that point where it's time to corral it in and go for it.
Well,
So-
and when we've had potential data breaches and things
Yeah.
like that,
Yeah.
that's critical to have somebody
Yeah.
on site.
Yeah.
Would we get to have the same person?
It would be an employee dedicated to us. They would, Monday through Friday, in the office space there, and would be
Great.
hours essentially. So
And this person would speak Cerner?
we would,
You know
yes,
what I
they
mean?
would learn the systems in and out and to
Great.
be truly be reliable in that aspect. So yes.
And so they're certified in everything that we need them to be
Yes,
certified in?
healthcare and everything. And then again, they have that higher level of engineers and people available. So when there is a significant issue, something they
What I
can
like
resolve,
is-
they can,
Yeah.
you know, bona fide.
I like the idea that Cynthia is not going to be the hands-on trying to tell people what their password needs to be. She can focus on being a CFO.
Yeah.
Let's
Yeah.
get away from this business of her being the IT person and let these people do their job, you know. I mean, I think that's just crucial to what we're doing, that you do your job and not bail everybody else out, you know.
And Pinnacle, Kate, is a healthcare specialist. That's how they
Right,
start.
I just wanted to make sure
Yeah.
they spoke
Yes.
Cerner. How soon would the full-time person be able to come on board?
I think we're looking around June 1st.
Oh, it's almost here.
Yes.
Okay, we don't need to vote on that. That's an administrative decision, but I just wanted to bring it up and discuss it, and any questions at all, so. And you're good with it, and it'll save you?
Yes,
Okay.
absolutely.
You said we don't have to vote on it, right? Or did you say?
No, we don't have to vote. It's administrative.
Great.
Yep.
Okay.
We've already voted for Pinnacle. It's just an addendum, so they
Awesome.
can handle it from there.
In 5, so consent.
See, that's it. We talked about the budget workshop on it. Census reports and your stat reporting and everything, is there a way we can formalize that? City Council has requested updates, and it looks like I might be on the agenda every month. Just census and data tracks, how many patients, how many life flights, things like that. Can you formalize that
It's
for
a
us?
report we can run out of Oracle, so there's no manual formulation. We can run an ambulance report, we can run the daily acuity census out of Cerner, so they're not,
Super.
they're just reports we can run just straight out of Cerner that would give us how many ambulance, you know, we've had arrivals to our ED, what our daily census versus our monthly, so there's no manual manipulation, and it is an Oracle report.
Super. So can you run those monthly for me?
Yes,
That's
yes, we
great.
can.
And there were some other reporting or census things that the two of you talked about a couple of months ago on tracking some things. Was that diagnoses, or what was that about? Do you remember, or am I spacing?
I think,
You said I had the stroke and STEMI stuff.
Okay, that's what I was thinking. Okay, great.
Each of those, they're called time-critical diagnosis, TCD diagnosis, stroke, STEMI, and trauma, and each of them have a dashboard. You know, total patients admit that were trauma, how many were stroke, how many were STEMI, you know, and then kind of just different goal demographics about them, time to CT, time to EKG, you know, certain things and the different service lines that you track.
Great.
But each of them has, we refer to it as a dashboard. It's kind of it's some
That's what I was
so is the
thinking about.
dashboard working now? We're using it now, correct? Or, no, we,
Well, I have to be honest, we created it, so of course it works.
okay. Yeah, so it was something that you guys
It's
put
more of
together.
a tracking and a trending dashboard.
Okay.
Yeah.
Imagine Excel for tracking trends. So if I
I-
want to know what our challenges are from a trauma standpoint, I can look at that dashboard and see that we struggle getting to CT in 20 minutes, because my average time would be 35 minutes.
Well, that report that.
And that was just an example.
Yeah, Lana, you put that report together for us, what, a couple months ago, or what we looked at, one of the meetings that showed how how far we were performing above and beyond the norms.
Right.
Is that kind of the dashboard? Is that what
Correct.
we're, okay.
Well, while we're talking about all that then, are we able to include discharge dispensation, home alone, home with family, home with friend?
If the discharge disposition, it is on the, there is a discharge registration report we can run, and it shows kind of where they discharged, where they transferred to higher level of care, where they discharged home, long-term care. Yes, that is a report we can run as well, Kate.
And so all those numbers, we would be able to go over that in a workshop once a month, or,
Yes.
I think we should.
since these are being recorded
Well, and
on
then-
camera, then workshop would be a fine time, I guess, to
Yep.
just go over it and crunch numbers, I guess.
And I think when RHRC comes in and the staff meets with them, and did you say you have a locked date on when they're coming in?
We have not settled
Okay.
yet.
And staff's going to meet with them first, right? And then,
Correct. One commissioner can come join us if they'd like. I've asked if they will record our meeting so that it can be shared with the rest of the commissioners.
cool. So that coupled with, because they're going to have some information too, not only the financial end of it, but health equity, and that coupled with it, that's going to give us a nice snapshot, plus what we've done already and have from their first report and what we did. So that'll be a meaty workshop. And also, they're going to identify other opportunities to grow outpatient and other services. And the other thing I wanted to mention at our next, and I believe they're confirmed, 360 for our next commission meeting at the end of this month.
Yes,
And it's Misty and Dr. Roberts, and
and others. I'm not
You know-
sure who all.
they told Jody that they've got tons of ideas. And so they want to present those. So that's going to be predominantly our May meeting. So that this month should be critical in data gathering, anecdotal gathering, finally getting some track record, against a baseline that we could do to where we can really kind of put some solid programming and strategies in with the plan.
You may not know the answer to this, but with the trauma survey in the first few days of June, how quick's their turnaround on our score, our report card, and do you think it would be back in time for the June regular meeting?
Official report will come out 6 weeks after they
Oh, okay.
leave, but we'll know that afternoon.
Oh, okay.
The exit interview?
But official notice will come 6 weeks, but we'll know. And you're talking a little bit about data, and you ask like about home, and then always remember your electronic health record is like a financial institution. If you deposit it in, you can ask for it back out. Average age, day of the week, male or female, what is the mechanism, what is your chief complaint, any of those, if they transferred out, went home, went to long-term, whatever you want to know. If it's, and that's why the EHR, the Cerner is so important, is that we need to be able to put in a complete medical
Yes.
record so you can
Yeah.
pull information out of it, for
Yeah.
whatever reason.
Yeah. Well, I think the things that we query will help our local population understand us better and improve the confidence that we can do your pneumonia, we can do your biking accidents, we can, and this was the dispensation of this particular, this pneumonia person was able to go back home because they stayed with us for 23 hours, and I just think that we can pull a lot of good stuff out of the record to share with the public.
Well, we need it to educate ourselves as well, Okay, any other questions? Vivian, anything? Hope I didn't lose her. Huh? I think I lost her. Okay, the last thing, a couple of things. Our candidate of choice, that I got in trouble for using that, Tiffany Means is back in the country. She's been in Peru and Japan. She got back on Friday or Saturday. We're going to have a conversation this afternoon at 4. So we'll get back into negotiating with her, and I'll keep you updated, and we'll take it from there. Does anybody know about the Carroll County Hometown Health? I know you guys do. Have you ever attended? Samantha Jones used to attend on our behalf, but it happens on a monthly basis. The next meeting is May 7th, which is Wednesday. I can't go. I will be in Santa Fe, New Mexico. Thank you very much, till the 14th. First vacation in 8 years. I'm not going to come back to attend this, I can tell you that. Does anybody want to go and represent us at this?
What time is it?
It's at noon at the Berryville Community Center.
Let's think about it. Let's think about it. Let me think about it.
It'd be 2 days from now. Yeah, like
May
this
7th
Wednesday.
at noon at the community center.
Oh,
They have guest speakers. Again, I've never been, so I don't know,
What to expect or what?
what to expect, but the agenda is pretty detailed, I think.
So it sounds like it's once a month at noon on whatever day they choose at the community center, what it's going to be. So maybe we can make that
Yeah.
where somebody's,
Carroll County Hometown Health Coalition. Yeah. It was organized by Rob Kirby, who is he runs the Green Forest Chamber of Commerce and does some economic development, but I think it's just kind of a loose-knit coalition to collaborate.
Berryville
And I think
Center.
that,
Get that to
huh?
throw it in the table. She looks like she might be interested in going. She might be interested in going.
I think that's all I had. Does anybody have anything else? Nope. So our May regular meeting is going to focus on 360 and their presentation predominantly. Any update with the CEO that we have on that? We'll probably workshop and look at Dr. House's proposal in June and compare and contrast. And I'm doing some research. There's some legal issues and some question marks on that to go through. We'll probably revisit that in June. And then July budget workshop, hopefully, to get that going. So we should have a lot more data and information by that time to really kind of put our budget on a correct course. And you feel like we're doing okay now? Yeah? You guys are doing a terrific job. I mean, just spending a week with auditors alone amazes me, and doing the other work. Excited the lab's going to be back up and running, and thank you guys for getting us through the bad stuff and getting us on the right track. We now have it all corrected. So, proud of that. Anything else? Good. All right. This concludes the workshop for May 5th, 2025. Thank you all.